This is the lecture for Chapter 25, Drugs Treating Rheumatoid Arthritis and Gout. Here's your concept map for those particular drugs we'll be covering in this lecture. Which of the following is the underlying cause of rheumatoid arthritis? That would be autoimmune, because rheumatoid arthritis is an autoimmune disorder. It is a systemic inflammatory disease. The effects are not limited to joint destruction. Rheumatoid arthritis affects all age groups. It is thought to be an autoimmune disorder. And the primary characteristic of RA is symmetric polyarticular inflammation. And that's demonstrated here in these pictures. You can see the way that of the curvature of those particular joints and how it has been affected by RA. It can cause inflammation of the glands, the linings of the heart, the lungs, and the vascular system, which is the reason why we treat it quite, aggressively when we first recognize it. The clinical course of RA is highly variable. It depends on person to person, and it depends on and it depends on the rheumatologist as well, and how they want to treat it. It has a substantial effect on the quality of life because of the associated pain, fatigue, and depression, and the increased risk of heart disease. The associated pain and the pain and the fatigue causes such a degree that that's what leads to the depression. The pain and the fatigue become, so intense that then the patient can't sleep. So then they get in a cycle of not being able to sleep, which then in turn, makes depression worse. They're depressed over the fact that this is such a, lifelong chronic disease, and they realize they're always going to hurt the way, that way. So, in looking at the joints here, Figure A is a normal joint. Figure B is an early rheumatoid arthritis joint, and Figure C is a late rheumatoid arthritis joint. And so you can that figure is on page 462 in your book, but that is how the joint progresses there. In talking about gout is a disease of purine metabolism. It occurs when hyperuricemia forms monosodium urate crystals, which precipitate into the synovial fluid and initiate an inflammatory response. Hyperuricemia is clearly a risk factor for the development of gout. Hyperuricemia is an elevated uric acid level. The onset of an acute gout attack is rapid, and the diagnosis of gout is made definitively by analysis of synovial fluids, but we can also check a uric acid level and a sed rate and C-reactive protein, or CRP, level in blood work in a serum sample. Those are pictures of the urate crystals. That is also in your book. That's on page 464. All right, in talking about disease-modifying anti-rheumatic drugs, or DMARDs, they are used in conjunction with salicylates and NSAIDs, or they can be used as monotherapy in the treatment of rheumatoid arthritis. They are so named because they are capable of arresting the progression of RA and can induce remission in some patients. The therapeutic class of DMARDs is a combination of several different pharmacologic classes of drugs. One thing that I will say about that is that you can look in your book on page 465, table 25.1. There are lots of different disease-modifying anti-rheumatic drugs that are listed in your book, and because there are a vast number of drugs that fall into that category. Our prototype drug for the DMARD class is methotrexate, or Rheumatrex. There's that summary of the table that I was talking about that's on page 465 in your book. On the core drug knowledge, Pharmacotherapeutics, folate antimetabolite used in treating various malignancies and rheumatoid arthritis. Pharmacokinetics, it is administered orally or parenterally, metabolized in the liver and excreted in the kidneys. Pharmacodynamics, it exerts immunosuppressive effects by inhibiting the replication and function of T lymphocytes. Remember, that's one of the white blood cells that stimulate the production of cytokines. And those are, and all of this is, covered even in greater detail in your book. So I just encourage you, to look at that if it doesn't make, so much sense to you. All right, contraindications and precautions. Immunosuppression, because of the fact that this drug is going to suppress the immune system itself. If someone is already immunosuppressed, we wouldn't want to give it to them. Blood dyscrasia, pregnancy, and lactation. Those are reasons why. If they and that's a pre-existing immunosuppression, a pre-existing blood dyscrasia. Also, I'll add to that impaired bone marrow functioning. And during pregnancy and lactation, like I said. Adverse effects. There are numerous adverse effects that are listed in your book. Stomatitis, mild alopecia, hair thinning, oral ulcers, and GI upset are related to the folic acid antagonism that's going on, because remember we said that this was a folate antimetabolite. So the folic acid there is going to be the folic acid antagonism that's going on is going to lead to those particular side effects. Other adverse effects: rash, headache, nausea and vomiting, diarrhea, and then there at the end, stomatitis and alopecia, as well as suppression of the bone marrow. I will direct your attention to page 466, box 25.2. There is a whole box there of black box warnings for methotrexate. I would make sure to mainly just to look at that and realize some of those serious toxic effects and toxic reactions, because of the fact that there are so many. One thing you do need to know too, methotrexate is also used as a chemotherapy agent because of its immunosuppression. It's used for treating various malignancies, osteosarcoma, non-Hodgkin's lymphoma, Hodgkin's disease, T-cell lymphoma, head and neck cancer, lung cancer, as well as breast cancer. But how we're specifically studying it is because of its immunosuppressive effects in treating adult and juvenile RA and in treating psoriasis. So in keeping that in mind, that's going to be where you're going to see a lot of the black box warning information. So as far as drug interactions are concerned, there are multiple drug interactions. You can understand that there are lots of them that are causing, that are going to interfere with this drug because of its immunosuppressant effects. And so that's on page 467, table 25.2 in your book. We do want to assess for comorbid conditions. We want to give with caution to the young and the elderly. And we want to evaluate for alcohol and illicit drug use as well, because of the fact of the especially with like the liver, kidneys, because of the way that this drug is going to work inside the body. All right. It is routinely given at home. It's not something that that is necessarily just going to be hospital setting. We do want to administer the medication as ordered. It is usually given in weekly dosing. We want to ensure that the patient drinks enough water to minimize the risk of nephrotoxicity. That's one of the main reasons too, again, with the very young and very old, that kidney function. And another reason why with the alcohol and illicit drug use, we want to know about the liver functioning as well. In order to minimize adverse effects, folic acid will interfere with the effectiveness of the drug if taken in too large of a quantity. However, vitamin B, which is folic acid, 1 milligram PO daily may decrease the potential for adverse effects of methotrexate. And I will direct you to the box there, or the paragraph there about minimizing adverse effects on page 468 that goes into that. Another thing too is that we want to remind them that this drug may cause photosensitivity. So we do want to make sure that we are encouraging them to wear sunscreen, long clothing, long shirts, covering, hat, covering the ears, those kind of things. And again, that is listed on page 468 in your book. Patient and family education. We want to instruct the patient how to administer the medication properly. Again, that's taking it as ordered on a once weekly basis most of the time. Occasionally, you'll see rheumatologists who have made it to where they're taking it like one every other week, and all of that when they're in a more of a maintenance phase. We do want to teach them which adverse effects they need to report to us as the physician. Remember, this is going to suppress their immune system, so they need to be taught that they're not going to respond to infection in the same manner that you or I would, because this is going to immunosuppress them. So we do want to make sure that we've done good education on the things that they do need to report immediately. If they start running a fever at that point, they probably have already had a full-blown infection for a while, because of the fact that their body is immunosuppressed, so its first reaction is not going to be to get a fever. And so there are several bullet points listed there in patient and family education that tell you the ones that they need to report to the physician. So I would just make sure I looked at those. Ongoing assessment and evaluation. We want to monitor patients for signs of blood dyscrasias, suppressed bone marrow function, pulmonary changes, and hepatic or renal dysfunction. We're going to be doing routine blood work on these people. Usually when they come in to their rheumatologist or to their primary care physician, we're going to go ahead and do a comprehensive or basic metabolic panel, as well as doing CBCs on them, and most of the time a urinalysis, especially when they're just beginning treatment. We do want to effective treatment with methotrexate should show improved symptoms with few side effects. So that's the way we're going to know if it's doing what it's supposed to do. Methotrexate is a pregnancy category X drug because fetal abnormality has been documented with methotrexate, and actually methotrexate is given a lot of times and I say a lot of times, it's given if they already know that a patient is miscarrying, they will give methotrexate to patients to go ahead and complete that miscarriage, in case so that they don't have to go in and do surgery. And so it will usually cause to go ahead and complete the miscarriage process. All right, on your memory chip that's on page 469 on methotrexate, most common adverse effects being nausea, headache, stomatitis, gingivitis, and alopecia. Most serious adverse effect being depressed bone marrow function. To maximize therapeutic effects, they do need to remain hydrated, drinking lots and lots of water. And to minimize adverse effects, they need to take vitamin B, 5 milligrams every day. So they're taking the folic acid. All right, so next is tumor necrosis factor inhibitors. Enbrel was produced by recombinant DNA technology. In the past, TNF inhibitors were used in patients who did not respond to methotrexate. Now we see more a combination therapy, because used to it was if they had to have tried and failed methotrexate before moving into the tumor necrosis factor inhibitors, which a lot of times insurance is still kind of requiring some of that. But now the gold standard for RA treatment is combination therapy with the TNF inhibitors and methotrexate, because it has shown exceptional results. These are drugs that block the tumor necrosis factor, and so they're going to decrease inflammation. And so that's the reason why they are a TNF inhibitor, because TNF is a pro-inflammatory protein. It is one of the proteins that's going to be released in that inflammation process, and so that's the reason why we're giving a blocker or an inhibitor of TNF, because it's going to decrease the inflammation that way. Prototype drug here, etanercept is the prototype drug, or also known as Enbrel. Enbrel with an N, not an M. All right. Pharmacotherapeutics, it is used in managing RA, and it also can be used in psoriatic arthritis, ankylosing spondylitis, and moderate to severe active plaque psoriasis. Those are listed in your book, but primarily the way that we're learning it is its use in managing RA. Pharmacokinetics, it is a weekly subcutaneous injection. Its onset is slow and its duration is uncertain. Benefits from therapy can begin in a few days, but it may take up to 12 weeks. And so patients need to know that that's variable from patient to patient. Pharmacodynamics, it binds specifically to circulating TNF, prevents it from binding to TNF receptors on the cell membranes, and prevents the TNF-mediated cellular response. Contraindications and precautions. The only absolute contraindication is hypersensitivity, and I will add here, and current active infections. However, there are lots of cautions that should be used with this particular drug, and I'll just direct you to your book to go into reading those. But the only absolute contraindications are hypersensitivity and a active infection, a current active infection. Adverse effects. Injection site reactions, obviously because it's a weekly sub-Q shot. Upper respiratory infections, headache, nausea, and rhinitis. Serious effects would be induction of demyelinating diseases and blood dyscrasias. And there are some other less common side effects that are listed there in your book that you can go into. There are 3 important black box warnings for all TNF inhibitors. The first is a reminder to weigh the treatment benefits and risk in patients with chronic or recurrent infections, pulmonary and extrapulmonary tuberculosis, invasive fungal infections, and other opportunistic infections. The second is it gives an increased risk for lymphoma and other malignancies, especially in children and adolescents. And in addition, it may induce hepatosplenic T-cell lymphoma, a rare type of cancer, which has occurred most frequently in teenagers or young adults. And so I would make sure that that you understand there are some black box warnings to this particular drug. Drug interactions, many other drugs that are used to treat RA interacts with Enbrel, especially other biologic DMARDs. Co-administration with another TNF inhibitor does not improve the effectiveness of the treatment, but it does substantially increase the risk for infection. And that table for drug interactions with Enbrel or etanercept is table 25.4 on page 473 in your book. All right. Health status, we want to assess for comorbid states or contraindications to therapy prior to giving this drug. It is a pregnancy category B drug. We do want to evaluate their nutritional status before we begin treatment, because of the fact that of the way that it's going to work in the body. We want to make sure that they've got a good protein level and that they've got a good nutritional status before we begin. Also, it is generally administered at home. Does not have to be administered in the doctor's office because it is a sub-Q injection. It's going to be something we're going to teach the patient to do. Maximizing therapeutic effects. We want to make sure that they understand that it is a weekly injection and it needs to be given as prescribed. We do want to make sure that they understand to rotate those injection sites so that they don't get, the knots and things like that with the lipodystrophy that can go on. Minimizing adverse effects. We need to teach them how to give the administration. They need to use aseptic technique when they are administering it. They do not need to administer if the drug solution is discolored or cloudy or contains particles. And they also need to understand that they are not to get any live virus vaccines while taking this drug because of the fact that it is an immunosuppressant drug. And so they don't need to get any live virus vaccines. I will tell you too, even though it is given in the home, we do need to make sure that we assess whether they are living with or have close contact with anyone who has active TB. If they are actively having, if a patient actively has TB, they don't need to be around them because of the fact that they're going to be immunocompromised, so they're going to be quicker to pick up TB. We do want to teach the patient the symptoms the patient and family the symptoms that they need to report to us should they start having problems. Again, those are listed in your book, goes over some of the same stuff that we covered with methotrexate. We want to teach them the proper preparation and administration of the drug. We want to stress the importance of avoiding others who are ill because while they're while they're taking this drug, they are immunosuppressed. So a common cold to them is going to be, or a stomach virus to them is going to be way, way worse than it is for us. Also, one thing in talking about on this page and talking about the things that we need to assess with the patient kind of goes into it here. We say on the ongoing assessment evaluation, assess for improved range of motion, decreased early morning stiffness, and painful and swollen joints. We need a baseline of that, and so we need a baseline to know how well they're able to move and all on their own before we get started. So because then that will be what we will use to note if they're having improvement, because if they can move better, if they have decreased early morning stiffness, if they have decreased painful or swollen joints, that will help. That will tell us that the drug is helping. We do want to coordinate lab testing for CBC, CRP, that's the C-reactive protein levels. ESR is the sed rate there. I think it's the erythra. It's the erythropoietin sedimentation rate, I think is the way that is what it stands for. I'll look that up and let y'all know before the lecture's over why it's ESR. Can't come up with the E right off the top of my head. And then we also want to review aseptic technique. Every time that they come into the office, we want to make sure that they show us how we're going to be how they're going to be given the drug, and make sure that they understand those particular injection techniques. Etanercept has been approved for children as young as 4 years old. It is not approved for use in children under the age of 4, nor can I think of a reason why you would really give it to anybody under the age of 4 anyway, because most of the time juvenile RA is not going to be diagnosed below 4 years old anyway, because they need to be able to tell us that they're hurting and all of that, and that's kind of hard to diagnose without them being able to give us a good history. All right. On the black box warning, it's on page 474. Again, most common adverse effects being nausea, headache, upper respiratory infections, and injection site reactions. Most serious adverse effects being severe infections and blood dyscrasias. And then again, the black box warning information, the risk-benefit ratio due to serious infections and malignancies, and an increased risk for lymphoma with children and adolescents. There are other drugs that are in the TNF TNF inhibitor drugs. Those are listed as well. I believe they're in this table. Hang on. No. They are listed on page 472 in your book, table 25.3. Those are the various drugs that are listed that are similar to Enbrel. You've got Humira. It is also sub-Q every other week. And then also you've got Remicade. It's another one that a lot of patients will do. It's IV every 8 weeks. And then another one that a lot of patients use is Orencia. And I have a few patients that use Symphony, and then Actimera. I have a few patients that use that as well. All right. Going into the anti-gout drugs. Anti-gout drugs are used to treat acute cases of gout and to prevent gout. Anti-gout drug therapy focuses on either decreasing the inflammatory response caused by hyperuricemia or reducing hyperuricemia itself. And the first line drugs for acute gout are NSAIDs. Those are the main ones that we're going to use. And specifically, the ones that we use the most, or that I use the most, is indomethacin. Excuse me. Second line drugs are colchicine and glucocorticoids. So sorry. Our prototype drug is colchicine. Pharmacotherapeutics, treating acute gout and as pre-surgical prophylaxis to prevent gout. Our pharmacokinetics, it is administered orally or IV. It's metabolized in the liver and excreted in the feces. It is occasionally effective for other types of arthritis. It is also used non-FDA approved uses or off-label uses. There are a few of those listed in your book as well. The brand name that this is marketed under now is called Colchris. The pharmacodynamics, it inhibits the activity of leukocytes by decreasing their migration into the affected area. Contraindications and precautions. Colchicine is contraindicated in cardiac disease, hepatic disease, and renal disease because of the fact that these patients are at risk for developing a cumulative toxicity. Your adverse effects, there's also other people who are at risk for cumulative toxicity are elderly or debilitated patients, and they should just be monitored closely. It's not a contraindication in those patients. It's more so just a precaution, but it is contraindicated in cardiac disease, hepatic disease, and renal disease. Adverse effects, nausea, vomiting, diarrhea, abdominal pain, and paralytic ileus. And so we're going to tell patients to keep taking this drug pretty much until they start having diarrhea, like to treat an acute gout flare. We're going to have them start on it and then tell them once that the diarrhea starts, then they should stop taking it. So that's going to be a major indication there. And that's one of the main side effects is nausea, vomiting, and diarrhea. There are some other adverse effects that are listed in your book talking about long-term therapy causing depressed bone marrow function, aplastic anemia, pancytopenia, thrombocytopenia. And so you just need to monitor, for those as well. Radiation therapy, drugs that depress the bone marrow function, and cyanocobalamin, which is B12 or vitamin B12. Those are your main drug interactions. Those are listed on table 25.6 on page 478 in your book. We want to assess for conditions that are contraindicated in therapy. It is a pregnancy category C drug, and we do want to evaluate the patient's diet and make sure to see about if they need to be, because it may be that they're kind of precipitating their own their own gout flare. Alcohol and red meat are one of your biggest factors for that. So we want to encourage them to eat and also high consumption of red meat as well as seafood can precipitate that hyperuricemia and the gout flare. And so we want to make sure as well, like I said, for the alcohol and beef, to make sure that they get that education component. Colchicine is usually self-administered at home. It's mostly given in the PO form, not the IV form. So it will most often be given in the home environment. Maximizing therapeutic effects. We do want to administer with a full glass of water at evenly spaced intervals throughout the day because of the fact of the nephrotoxicity, as well as helping to flush all of that out of the body. all of the hyperuricemia out of the body. Adherence to diet and alcohol restrictions decreases hyperuricemia. And then also minimizing adverse effects. We want to monitor for any pre-existing medical conditions. And patients need to understand they need to start these medications at the first sign of an attack. They don't need to wait until, to see if it's maybe going to get better, or maybe I just stumped my toe wrong or whatever. They really need to understand that they need to start it at the first sign of an attack. Patient and family education. We want to discuss the importance of dietary restrictions and discuss the side effects of therapy and which ones they would need to report to us as well. And we want to monitor for hematopoietic and renal toxicity, and joint involvement, deformity, and range of motion. Therapy is considered effective if the patient reports decreased frequency of acute gout attacks and remains free of adverse effects. Colchicine is considered first-line therapy for acute gout. And that would be false, because first-line therapy is NSAIDs. Colchicine is considered second-line therapy, not first-line. On your memory chip on page 479, most common adverse effects related to the GI system. Most serious adverse effects, blood dyscrasias, including bone marrow suppression. And most important patient education is related to diet and alcohol restrictions. All right. Drugs for treating chronic gout. So allopurinol is used. Colchicine is used for an acute gout flare. Allopurinol is going to be for a chronic gout flare. Uricosuric drugs balance that urate concentration in the body. Because they have no anti-inflammatory or analgesic activity, they are not useful in treating acute gout attacks. And in fact, when they're first initiated, they actually can exacerbate an acute gout flare. So they're not going to usually be started right whenever a patient gets their first gout attack. It's going to be after that initial gout attack is over, and then we'll start them on something for chronic gout. And prototype drug here, like I said, is allopurinol or Xyloprim or Lopurin. All right. Pharmacotherapeutics, management of chronic gout, recurrent calcium renal stones, and hyperuricemia. It is administered oral or IV and metabolized in the liver. Pharmacodynamics, it decreases the production of uric acid by inhibiting the action of xanthine oxidase. Contraindications and precautions is hypersensitivity. We should give it cautiously to patients who cannot sustain a fluid intake of 2 liters per day, for example, those with chronic heart failure, because the fluid intake is required to avoid complications. And also we want to use precaution with people who have decreased renal or liver function. Adverse effects, pruritus, maculopapular rash, nausea and vomiting, elevated LFTs, and acute gout symptoms. Most common adverse effects are those listed there. Serious adverse effects being blood dyscrasias, myelosuppression, hepatic or renal toxicity, exfoliative dermatitis, and Stevens-Johnson syndrome. Drug interactions, it does interact with many drugs. Those are listed on page 481 and table 25.8 in your book. I'll just direct you to those so you can see some of the ones that interact with it. The health status, we do want to assess their medical history to make sure that if there's anything that contraindicates the use of allopurinol or anything in specific that we need to monitor because of their past history. We want to have a baseline CBC, uric acid level, liver function, and a metabolic profile. We also want to assess their range of motion of the joints, the joint stiffness, as well as their pain level. It is a pregnancy category C drug. We do want to administer this drug after meals to decrease the potential for nausea or vomiting. and we want to encourage them again to follow the same diet plan for patients who are taking colchicine to avoid decreasing the efficacy of the drug therapy. We want to teach them to drink 2.5 to 3 liters of fluid every day to avoid renal calculi. That's kidney stones. So we want to teach them to really drink a lot of fluid there. We do want to administer allopurinol in conjunction with colchicine when they first start it. Again, that's because of the fact that it can precipitate an acute gout attack when we first start them on it. We want to assist them to develop meal plans that limit uric acid production, and again, that's going to be avoiding the red meat, the seafood, alcohol, beer, that kind of thing. Beer's really bad to cause it, more so than liquor and that kind of thing, but especially beer will precipitate it. Minimizing adverse effects, fluid intake should range between 2.5 and 3 liters per day. We do want to titrate the drug based on uric acid levels, and we will have to draw a uric acid level and a SED rate and a CRP on them whenever they come in. Whenever they're coming in for their regular visits, we're going to check those levels, and we're going to adjust that allopurinol dose accordingly. We do want to teach them to take the medication as prescribed, teach them the adverse effects and when they need to notify the provider, and teach them the importance of fluid intake and how much they need to be getting in a day. We also, in ongoing assessment evaluation, is considered effective when the patient reports reduced pain and inflammation and remains free of adverse effects. A contraindication for taking allopurinol is, the only contraindication is hypersensitivity.